I'm Carita Linden-Lahti, responsible pharmacist in medication safety from HUS Pharmacy and Helsinki University Hospital. And do you, Lotta, want to introduce yourself?
Hello, I'm Lotta. I think Monica told the main things, so
okay, the main things. Yes.
Yeah.
Yes. Okay, and this morning we are going to tell you some experiences with the electronic medication management system that we have implemented in our hospital. The topics in our presentation is, of course, some background about the electronic health record system with electronic medication management system that we have implemented in Helsinki University Hospital. And we are going to tell about the changes that we are required to do in our medication process and workflows while we had the implementation. And after me, Lotta will tell you about the effect that this implementation has had on the reported medication errors in our hospital. And then we share some discussion with you that how we see what is the value of the new medication management system to medication safety. And it is now few years after the implementations in our hospital, and we will discuss if we have any challenges left after that. And of course, is there something that we would have done differently if we will start the implementation now again? And we have published a scientific paper about this topic that we are going to talk today. Please see it also. It's published in MDPI Healthcare. It is open access paper, so that is more precise description what we have done, and now we have the main results in our presentation today. But please see this paper also. First about a bit setting where we are coming. Of course, we are coming from Helsinki, and that is the city in the south part of Finland, if you have ever visited there. And Helsinki University Hospital provides secondary and tertiary care for a population of 1.6 million inhabitants in the capital area of Finland. And Helsinki University Hospital is not a hospital. It is 23 hospitals in that capital area. Last year, we had about 700,000 patients treated, and in our hospitals, there are about 3,000 hospital beds. So you see that we are quite a large hospital also in European setting, and our hospital pharmacy is also quite large. We have about 400 pharmacists working in our hospital pharmacy, and of course in our hospitals in this capital area. I'm going to tell you about electronic medication management system, EMS, and first a bit about it. It is, in brief, it is a closed loop system that encompasses prescribing, administration, pharmacy verification, smart infusion pumps, automated dispensing cabinets, barcode medication administration, and anything that has electronic medicine datasets or encompasses with medication management process. And according to previous studies, it really is the potential technology to prevent medication errors and enhance the quality of the medication process. And that is why we have also wanted to have it in our hospital. You can see here the process, closed loop medication management system process in one picture. This is a cycle or loop, if you call it like that, which starts when the physician makes the informed care decision, and optimally he or she has all these clinical decision support tools that electronic health record system provides. So they will make the right decision about the medication, and after the informed care decision, the physician will do the order in the electronic health record system. In closed loop medication management system, the order is the basis for the whole of the rest of the process. So it really is important that it is done in a right way, and all the essential things that has to be taken considered before, for example, interactions, kidney failures, or anything like that, allergic reactions. It is very important that all of those are taking account before the medicine is going to give into the patient. And that is why in closed loop medication management system, there usually is a phase order review or order verification. This means kind of double checking the order before the patient gets it. And also in HUS we now have it that in the pharmacist in some of the units, they will have the orders that include some high risk medicines, and the pharmacist is double checking that order before, hopefully before the patient gets it. In closed loop medication management system, also the safe storage of medication is very important, and using technology perspective to assist it usually is electronic dispensing cabinets or trolleys or something like that are integrated to the health record system, so you are able to take only those medicines that are ordered to the patient. Barcode medication administration is very important part of this closed loop system. We use barcodes when we dispense and prepare the medication, so we can make sure that we are really dispensing and preparing the medicine that the physician had ordered, and the barcode says that yes, this is the right medicine that you are dispensing. At the moment in Finland, we don't have unit doses. We are only able to make sure that we have the right medicine, but we are not able at the moment to count the tablets that we have dispensed. The administration part of the process is also important, and in that phase also the barcodes are used that we recognize that we have the right patient, and in a bedside, of course, we also recognize that we still have the right medicine that we are going to give to him or her. Medication administration should be recorded electronically at timely basis in the bedside of the patient, and also medical devices should be integrated to the electronic health record system, so that the information from those goes straight to the system, how much medication the patient has given. And last but not the least one is also the patient monitoring and documentation. We need to know and document how the medication has affected to the patient, because when the closed loop goes to the next phase, when the physician again starts to think what is the right medication and dose for the patient, he or she really has to know what has been given to the patient when and what has been the effect. So this is like a closed loop where we are using every technical advices that is possible to save it as much safe as the process can be. Okay, and now to the electronic health record system that we have in HUS. Already many years ago, HUS found out that we really need a new electronic health record system, and the EPIC-based Apotti was chosen. I will going to tell about Apotti. It's EPIC-based. Before Apotti, HUS had multiple electronic health record systems in a hospital, and usually that meant, especially when considering medication, that we had to transfer manually medication information from one record system to another one. And now after Apotti, we have only one system in the entire hospital, so not anymore multiple systems. So that is not no manual work anymore. And why HUS chose Apotti is one reason was that it enables a closed loop electronic medication management system that I described in my last slide. So that is one reason why we wanted it, because we want to have this management system in our hospital. Apotti was implemented in HUS in 4 phases. We started with 1 hospital in November 2018, and then we had 2 big go lives in 2020. We have the last go live in April 2021, but it was not related on medication management, so all the problems came visible in those first 3 go lives that we have in 2018 and 2020. So it's now about 2 years that we have after last big go live that was related on medication management. So we take use a whole new electronic record system, but it was not only big change that we have, it was also a big change for the medication process and the workflows of our professionals. It changed really much in our hospital. For example, in medication reconciliation, before Apotti, it was hospital policy. You can do it if you want, and it was documented in free text, and pharmacists were not widely involved in the process. But after Apotti, it's quite a mandatory. You have to have the home medication list before you can do in Apotti inpatient medication list. And the home medication list is based on electronic prescriptions. Apotti is integrated to the Finnish Kanta system, which holds those electronic prescriptions. Lotta can tell that there are some challenges with that, but it was a new way to have some kind of basis for the home medication list. In Apotti, there is also an application for the patients, so the patient can see their medication list electronically in a home. The patient application is called MISA, and of course we can use the MISA also when the patient comes to the hospital and see the medication list with him or her. And medication reconciliation is very resource consuming, and it really needs a knowledge and competence, and we see it now, and that is why pharmacists are very much involved in the medication reconciliation in many units at the moment. Prescribing also changed a lot. Now prescribing and ordering is made in a structured form and with generic names. We have more sophisticated clinical decision support system. For example, we can use electronic best practice advices. And before Apotti, it was primarily nurses who transcribed the orders. The physicians make free text order, and then the nurses transcribe it as an order in medication list. But now after Apotti, it is really primarily a physician who documents the order directly to the patient's medication list. And that is really good because when doing the order, they have all these clinical decision support system warnings that they should take account when they are choosing the medicine and the dose. And now we also, with the Apotti, we are able to do electronically pharmacist verification. And like I said, in HUS, the high-risk medicine orders go to the pharmacist to have verified. In dispensing and preparing, now the automated dispensing cabinets that we have, they are integrated to Apotti that enables us the dispensing of medicines according to electronic orders. We have changed also the dispensing process so that the dispensing and preparing of the medication is timely basis, maximum 2 hours before administration. And now we can use the barcodes scanning that we have the right medicine dispensed or prepared. The barcode is also the way how we double check that we have the right medicine dispensed or prepared. A manual double check process is used only when the barcode is not available. Before we had Apotti, the manual double checking was the main process that we used. And as you know, it is very research and time consuming. And in the situation that we are lacking nurses, we really have to have some kind of things that we can make easier and without the people by using, for example, barcodes. It's also safer for the medication safety. In medication administration part, there is also big changes. we can use barcodes also in that part of the process, assuring that we have the right patient and the right medicine, and medication administration is recorded on a timely manner at the bedside. So we have these kind of hand computers for the nurses, so they are doing it in a bedside, and all medicines at the moment are recorded. So now I told you that we have this new system for this electronic health record system that includes this possible for the electronic medication management, and we have made some process changes, and now Lotta will tell you how it has affected on the reported medication errors in our hospital.
Thank you, Carita. So we knew before from the earlier studies, you can change the slide, that some hospitals have reported implementing EPIC, and they had reported some new challenges, but also findings of safer processes and improved documentation have been published. And there is a need to understand how EHR based on closed-loop medication management system affect medication errors, and which errors might be the new medication safety concerns. And we made this study to describe the changes in our medication error reporting during and after implementing this Apotti system. Next, please. So we used our medication error reporting data from January 2018 to May 2021, 6 months after the last go live, which concerned medication management. And for electronic medication error reporting, we use HiPro system, which is in use in more than 60% of hospitals in Finland. And we have used it since 2007. So it's very familiar to our staff. And we also took also the severe medication errors and analyzed them separately with qualitative inductive content analysis, and divided these into 3 categories, like technical failures and flaws in Apotti, proper use or users' knowledge and skills, and both of these, because these were not the used categories, but we needed from this perspective the information, so we made new categories for this study. And during this study period, 30% of all reported patient safety incidents were related to medication errors, which is kind of the similar as earlier years. And patient incident reporting activity increased annually during the past few years, but in 2020 it decreased for the first time. And we are speculating that the pandemic situation have had the impact on this reporting activity. Not much, but we can see the change. And the medication errors were the most reported error type in all 4 years. And we saw that different implementation phases momentarily increased the number of reported medication errors, but then soon it decreased back to earlier level. And we saw that administration and dispensing errors decreased, but medication reconciliation, ordering, and prescribing errors increased. We also checked the ranking of top 10 medication or top 20 medications related to medication errors, and those top 10 remained relatively stable. Next one, as here you can see the trends in all reported medication errors. And the red line is the errors which reach patient, and the blue line is all medication errors. And orange lines, you can see the implementation phases, and you can see the peaks in the medication error reports, but then they are decreasing back to earlier level. Next one, we have separated the different medication error types, and the orange line here is administration errors, and you can see some peaks also in it, but then it's coming the lower level than before the first implementation. Red line is prescribing errors, and as you can see, it's very much like increasing, and I will come back to that later in this presentation. We also had to change a bit our medication error reporting categories, because we didn't have earlier an own category to medication reconciliation. So the purple line in the end is the new category. And also through this change, we could make these errors more visible than earlier. We also made a change in the beginning of 2020 that we embedded the documenting errors to prescribing errors, so it also might have made some effect and made these prescribing errors more visible. And the next one is about top medication. As you can see, the top 5 is kind of the similar through all these years. There is some interesting changes, for example, levothyroxine, and it hasn't been in the top 10 earlier, but now it's like going higher and higher. And the reason for that is that it's ordered different dose for different weekdays. For example, X milligrams for Mondays, Wednesdays, Fridays, and Sundays, and other dose for Tuesdays, Thursdays, and Saturdays. And physicians must link these 2 orders together in our new system. Earlier, it was easier to make in one order, and it's not very severe error type, but it's tricky for them to link these orders. And this autumn we got a new panel for that for physicians, and those linkings were made ready for them. So now we are hopefully seeing that levothyroxine errors will go back to lower level. And we have 96 severe medication errors. It was 43% of all severe medication errors. So it was very big number, but our professionals were very aware of reporting severe cases, even if they didn't reach patients. We took them in the root cause analysis if it could have had severe outcomes to the patient. And usually those were linked to several medications, for example, problems in the entire medication list or medication reconciliation, including ordering, prescribing, at admission, transitions, at discharge. And most of the errors were related to use and user skills, and the rest were technical failures and both of these. So what's the value of the new electronic medication management to medication safety? So we were able to take the first features of EMMS in use, and now we have better documentation of each step of medication management process. And medication reconciliation is a mandatory step, and pharmacists are widely involved. The Apotti system seems to provide a safer dispensing and administration of medication because we use barcode scannings, and our automated dispensing cabinets are integrated to HAR system. This might make ordering and prescribing errors more visible than earlier. I think they have been underreported earlier. And we have more sophisticated CDSS. We have order verification, which is totally new task for clinical pharmacists in Finland, and I think we are only hospital in Finland using that. And also patient can read their charts and report their allergies and home medications with MISA app. The next one. So what kind of challenges we have left? The connection to Kanta, which holds our e-prescriptions, it's not working optimal because the data we get there is not in structured form. So we must do a lot of manual work at the medication reconciliation process. Hopefully in a few years we get structured prescription data, and there will be only updated medication lists, not all the prescriptions that patient had, even if they don't use them or if they are old ones. So it's not optimal yet for this process, and it's very time consuming. We find that this structured ordering and prescribing is still challenging for our physicians, especially those orders which need linking, as I told you about levothyroxine. And also following the formulary, it's a bit hard, and Apotti doesn't have very good good features for that. And it's very important, especially when you are using ADCs, automatic dispensing cabinets, because there will be only formulary drugs, and if physician use some other drug, it's always tricky for the process the order must be changed to the formulary order and take some time. We also see alert fatigue related to CDSS, so it still needs optimizing and continuous management process. And we will concentrate next year to optimize this. And our barcode scanning rates are not at goal level in every unit, so still needs to work on that. And not in use in every setting. For example, ORs or ambulatory clinics, they are not widely using those yet. So hopefully we can get those in the scanning process in some years. So what we would have done differently, I think we should have done more usability testing before implementation. It's quite common in the IT business that they use this minimum viable product strategy, and it has many disadvantages, especially regarding patient and medication safety. It means that they bring a product that it's barely usable, and then they develop it while people are using it. And I think it's not very good strategy for healthcare, especially in this tertiary care where it's so tricky patients and so tricky medications. We should have allocated more resources, especially pharmacists, to the medication reconciliation process for the first implementation. But thankfully, we made this implementation in phases, so we were able to correct these to the next go lives. Physicians would have needed more mandatory training about ordering process. Apotti suggested that, but it was left for the leaders in the units to choose how much they want to train physicians. And I think they didn't have enough training for ordering process. And we could have started also pharmacist order verification earlier with proper resources if we were able to know before that this ordering would be so hard and tricky part.